Hi, my name is Andy Storm, and I'm the chair of endoscopy at Mayo Clinic in Rochester, Minnesota. I'm really excited to talk about our paper today, and on behalf of myself and my colleagues involved in this project, a big thanks to the GI editorial staff and reviewers. Our paper, titled EUS for the Evaluation of Esophageal Injury After Catheter Ablation for Atrial Fibrillation, is a very personal project for me. I grew up, my father was an electrophysiologist, and so I heard a lot about cardiac ablation as a kid. And growing up, I knew that one of the feared complications of an increasingly performed procedure, the pulmonary vein isolation for atrial fibrillation, one of the big fears with that procedure is thermal injury, particularly transmural thermal injury to the esophagus. So now, as a gastroenterologist, it's one of the things that we're asked to evaluate now and again. During my own general GI fellowship, about 10 years ago, a patient on our service experienced an air embolism because of a fistula that had formed after pulmonary vein isolation ablation. And of course, an endoscopy, which requires air or CO2 insufflation in order to visualize the area and describe, potentially to prognosticate the ulcer, it can result in further air insufflation, and worsening of a fistula can certainly result in an air embolization to the vascular system, which can be catastrophic for a patient. And so I was absolutely intrigued by the process here at Mayo Clinic, developed by Dr. Mark Topazian and others in our EUS practice, whereby we would use endoscopic ultrasound without the use of air insufflation to better study, prognosticate, but to evaluate for the presence of a transmural injury after AFib ablation. And this paper was really summarizing many years of experience and the team's approach to this complex patient issue. Our study was a retrospective review of 234 consecutive patients who underwent AFib ablation at Mayo Clinic between 2006 and 2020, followed by an EUS for the purpose of esophageal injury screening. In the study, EUS identified pleural effusions in 31.6% of patients, mediastinal adventitial changes in 22.2%, and mediastinal lymphadenopathy in 14.1%, with pulmonary vein changes seen in 10.6% and esophageal wall changes in 7.7%. We were able to conclude in our study that EUS safely assesses the mediastinal damage that may be seen after ablation for atrial fibrillation, and that it may excel over EGD for evaluating mucosal lesions of uncertain significance with a reduced risk of gas embolization in the setting of a full thickness injury or enterovascular fistula. We proposed an EUS first guided approach to post-AFib ablation examination, followed by EGD if it appears safe to do so. So in my clinical practice, when we're asked to see patients with suspected esophageal injury after AFib ablation, I take away a few clinical pearls from this experience. Number one, thermal injury most often occurs between 30 to 35 centimeters from the incisors, often seen as a small oval ulceration. Number two, examination with EUS first and no air or CO2 insufflation may be a safer option for patients to identify potential fistulae, as shown in this image, avoiding the risk of air embolization. Thank you again to the GIE team for this opportunity, and I hope you'll scope out our article in GIE titled EUS for the Evaluation of Esophageal Injury After Catheter Ablation for Atrial Fibrillation.